Med-SURG 2 Objective Sexually Transmitted Infections. Describe the various tests used to diagnose STI, and the nursing considerations associated with each. Explain why STIs must be reported to the health department. Individuals who engage in high-risk sexual behaviors are at increased risk for STIs. Patients diagnosed with more than one STI should be evaluated for others as well. Infections with some STIs actually appear to increase risk of HIV infection. Primary measures to diagnose STIs are serologic tests and studies of smears and cultures. Some OTC tests can be purchased for home or by mail service. Concerns with this type of testing include possible false negatives or false positives, uncertainty about reliability, and possible delayed treatment of serious infections. Serologic tests may be ordered to detect infections with hepatitis A, B, C, D, and E, syphilis, HIV, herpes simplex, and cytomegalovirus. These tests are designed to detect infections by measuring antigens or antibodies in the blood. May factors can cause inaccurate results, especially with older tests. Agency laboratory procedures specify the patient prep for specific tests. Smears, swabs, cultures, patients with gonococcal, chlamydial, herpes simplex, trichomonas, or yeast infections often have discharge from the vagina or penis. In addition to this discharge, exudate from lesions can be collected and studied to determine the exact infecting organism. For women, the sample may be collected from the vagina or cervix. The procedure varies with the type of organism suspected. To collect a sample from the male patient, a swab or special loop may be used. The person who collects the sample wears gloves and treats the sample as a potential source of infection. The sample may be submitted for microscopic examination or for culture and sensitivity tests. Always collect the specimen before giving the first dose of an anti-infective. Reporting STIs. Confirmed cases of HIV, AIDS, gonorrhea, syphilis, chlamydia, chancroid, and viral hepatitis are among the infections that must be reported to the local health department. An investigator asks the patient to name his or sexual contacts. Those individuals are contacted and advised that they have been exposed to the disease and are encouraged to seek medical evaluation. The purpose of this process is to identify and treat infected individuals so that transmission of the infections can be slowed. Another approach is to provide the patient with a prescription or additional drugs for his or her sexual partner without examination of the partner. This approach, called expedited partner therapy, EPT, is not legal in all states. Discuss drugs used to treat STIs. Antivirals. Drugs: acyclovir, Zovirax, valacyclovir, Valtrex, and famciclovir, Famvir. Use and action: decreases frequency and severity of genital herpes infections. Is not curative. Side effects: dizziness, headache, diarrhea, nausea, vomiting, renal failure, and seizures. Nursing interventions: apply ointment with gloved finger. Do not double up if an oral dose is missed. Tell patient drug is not curative. Condoms should be used during sexual contact, and sexual contact should be avoided when lesions are present. Dermatologic agents. Drugs: podophyllin, Podocon 25, imiquimod, Aldara, Podophylox, Condylox, and cunnicatecins, Cynecatecins. Use and action. Topical agent used to remove genital warts. Podophyllin, Podocon 25, side effects, highly caustic, can be applied directly on warts. Excessive application can cause kidney damage, neuropathy, blood dyscrasias. Teratogenic, contraindicated during pregnancy. Nursing interventions should be applied only by physician. Treated area must be washed with alcohol or soap and water within 1 to 4 hours. Imiquimod, Aldara, side effects, erythema, erosion, flaking. Local. Itching, burning, pain. No systemic effects. Nursing interventions, instruct patient to apply at bedtime and wash off in morning. Usual application is 3 times/week for 16 weeks or until warts are gone. Podophylox, Condylox, side effects, local inflammation, erosion, pain, itching, bleeding. Causes more discomfort than imiquimod but costs less and treatment is shorter. Nursing interventions, instruct patient to apply twice daily for 3 consecutive days, then take 4 days off. The cycle can be repeated if needed for a maximum of 4 cycles until the warts are gone. Does not have to be washed off. Advise patient not to use more than 0.5 ml/day and apply only to warts, not to normal skin. Cunicatechins, Synecatechins, used to treat genital warts. Side effects, erythema, pruritus, burning, pain, ulceration, edema, rash. Nursing interventions must be applied 3 times a day or for 16 weeks until warts clear. Advise patient to avoid sexual contact when gel is applied. Do not apply to vagina, rectum, or open wounds. Heart, highly active antiretroviral therapy, agents, a highly effective strategy to treat human immunodeficiency virus (HIV) infection by using various combinations of non-nucleoside reverse transcriptase inhibitors, nucleoside reverse transcriptase inhibitors, and protease inhibitors. Describe the pathophysiology, signs, symptoms, complications, and medical treatment for chlamydial infection. Pathophysiology. Although more than 30 different bacteria, viruses, and parasites are known to be transmitted through sexual contact, the World Health Organization identifies 8 that account for the greatest number of infections. These include syphilis, gonorrhea, chlamydia, trichomonas, hepatitis B, herpes simplex virus, HSV, or herpes, HIV, and human papillomavirus, HPV. The first 4 listed are curable with treatment, whereas the latter 4 are not curable at this time. Drug therapy. The drugs recommended by the Centers for Disease Control and Prevention, CDC, are noted with the discussion of each specific infection. The CDC also recommends alternate drugs for people who are allergic to the primary drugs, pregnant women, infants, and children, and people who are being treated for multiple infections. Details are available at the CDC. Drug therapy, drugs used to treat sexually transmitted infections, general considerations. Always assess for history of allergies before giving any antimicrobial. If the patient reports being allergic to the prescribed drug, withhold it and notify the physician. Observe all patients for possible allergic responses, rash, difficulty breathing, hypotension. Obtain specimens for culture before administering the first dose of the antimicrobial. When giving intravenous antimicrobials through a secondary line, check compatibility with primary fluid. Tell the patient it is important to complete the full course of treatment to prevent organisms from becoming resistant and to prevent relapse, because all organisms had not been killed. Tell the patient that the sexual partner or partners should be treated at the same time to prevent infection. Reporting sexually transmitted infections. Confirmed cases of HIV, acquired immunodeficiency syndrome, AIDS, gonorrhea, syphilis, chlamydia, chancroid, and viral hepatitis are among the infections that must be reported to the local health department. An investigator asks the patient to name his or her sexual contacts. Those individuals are contacted and advised that they have been exposed to the disease and are encouraged to seek medical evaluation. The purpose of this process is to identify and treat infected individuals so that transmission of the infection can be slowed. Another approach is to provide the patient with a prescription or additional drugs for his or her sexual partner without examination of the partner. This approach, which is legal in some but not all states, is called expedited partner therapy, EPT. Specific sexually transmitted infections. Chlamydial infection. Chlamydial infection is thought to be the most common bacterial STI in the United States. In 2016, 1,598,354 new cases were reported to the CDC, 2017. Chlamydia is an intracellular bacterium that comprises multiple genera and species. The specific species that causes the infection classified with STIs is Chlamydia trachomatis. This infection is transmitted by contact with the mucous membranes in the mouth, eyes, urethra, vagina, or rectum. The symptoms are like those of gonorrhea. Clinical manifestations can include urethritis, epididymitis, cervicitis, pelvic inflammatory disease, PID, proctitis, or pharyngeal infection, reactive arthritis, and conjunctivitis. Newborns of infected women may have eye infections, infant inclusion conjunctivitis, or infant pneumonia. Therefore, erythromycin ophthalmic ointment may be ordered for the newborn because it is effective against chlamydial infection as well as gonorrhea. Lymphogranuloma venereum, LGV, is a more invasive systemic infection caused by the LGV strain of C. trachomatis. Lesions may affect the inguinal lymph nodes and the rectal mucosa. Chlamydia facilitates the transmission of HIV. Signs and symptoms. One reason chlamydial infection is so common is that most people have no symptoms. Symptoms, if any, are generally noted 1 to 3 weeks after being infected. Symptoms are more noticeable in men and include penile discharge, which is initially thin and becomes creamy later. Another common complaint among men is painful or frequent urination. Women may experience vaginal discharge, painful urination, nausea, fever, painful intercourse, bleeding between menstrual periods, and lower abdominal pain. Rectal infection is characterized by pain, discharge, bleeding, or a combination of these problems. Unlike other forms of chlamydial infection, LGV patients have fever, muscle aches, swollen inguinal lymph nodes, and elevated white blood cell (WBC) count. Complications. If left untreated, chlamydial infection can result in sterility in men and women. The sperm ducts can become inflamed and blocked. In women, pelvic inflammatory disease, PID, which involves the ovaries, fallopian tubes, and pelvic area, can block the fallopian tubes and damage the uterus. The risk of ectopic pregnancy, i.e., the fertilized ovum develops outside the uterus, is increased in the presence of chlamydial infection. In addition, women with chlamydial infection are approximately 5 times more likely to become infected with HIV if exposed to it. Medical diagnosis and treatment. The diagnosis is based on the individual's sexual history and the results of laboratory studies. The nucleic acid amplification test, NAAT, is the most effective diagnostic tool. It has largely replaced the cell tissue culture. The infection is usually treated with a single dose of azithromycin, Zithromax, or a 7-day course of doxycycline, Vibromycin. Review the patient's complete drug profile, because azithromycin, Zithromax, interacts with many other common drugs. Other antimicrobials may also be administered, because patients with chlamydial infection may have gonorrhea as well. The test should be repeated 3 to 4 months after treatment to confirm successful results of treatment. The patient is advised to avoid all sexual contact, genital, oral, anal, until a cure has been achieved. When sexual activity is resumed, condom use is recommended to prevent reinfection. Describe the pathophysiology, signs, symptoms, complications, and medical treatment for gonorrhea. Pathophysiology. Transmitted most often through direct sexual contact. Can be transmitted to newborn infants, by infected mothers, and to medical personnel with skin lacerations who have come in contact with infected fluids. The infection is not picked up from toilet seats, doorknobs, or towels. The bacterium that causes this disease is Neisseria gonorrhoeae. This organism lives in warm, moist areas of the body, such as the cervix and the urethra. Areas affected by local gonorrhea infections may include the pharynx, rectum, urethra, prostate, epididymis, uterus, and fallopian tubes. A high incidence of rectal gonorrhea exists among men who have sex with men. The presence of bacteria in the throat is common among individuals who perform oral sex, fellatio, on an infected partner. With systemic, disseminated, infection, the heart, joints, skin, and meninges may become involved. Drug resistance, especially for gonorrhea, is a major threat to efforts to reduce the impact of STIs worldwide. Signs and symptoms. Many people with gonorrhea have no symptoms. When present, symptoms typically occur 2 to 10 days after exposure and are generally more apparent in men than in women. Men who do have symptoms often have whitish or greenish discharge from the penis and often complain of a burning sensation during urination. Testicular pain and swelling may be present. Women may experience vaginal discharge, bleeding during sexual intercourse, redness and swelling of the external genitalia, a burning sensation during urination, abdominal pain, or abnormal menstruation. A rectal infection may cause discharge, anal itching, soreness, bleeding, or painful bowel movements. Symptoms of rectal infection usually occur 2 to 5 days after infection, but may be as long as 30 days later. Throat infections usually have no symptoms, but a sore throat may be present. Symptoms generally disappear after a few weeks, but if the infection is untreated, the bacteria remain in the body and the person remains highly infectious. Complications. If untreated, gonorrhea can cause sterility in both sexes and infections that may lead to damage to heart tissue and joints. Men may develop epididymitis and prostatitis. Women may develop PID and ectopic pregnancy. People with gonorrhea are at increased risk for HIV. People with HIV and gonorrhea are more likely to transmit HIV to another person. Neonates may acquire a gonococcal infection during delivery from an infected mother. Medical diagnosis. The diagnosis is based on the individual's health history and physical examination findings, as well as on laboratory studies. Although smears and cultures of exudate from infected body parts or urinalysis are still used in some settings, NOTS are now the preferred diagnostic tool. Medical treatment. Treatment is usually initiated based on the physical examination without waiting for laboratory results. This is because many patients will not return for follow-up, and immediate treatment has been highly effective. Treatment usually consists of a single dose of intramuscular ceftriaxone sodium, Rocephin, and either azithromycin or doxycycline. One of these regimens cures most cases of gonorrhea quickly and safely. Penicillin is not used as much as it once was because many organisms have developed resistance to it. Erythromycin ophthalmic ointment may be ordered for the newborn to prevent eye infection caused by exposure to gonococci during delivery. Signs and symptoms. Possible complications. Medical treatment. Nursing considerations. Men, thick urethral discharge, purulent green or yellow, swelling and redness of the meatus, urinary urgency, and dribbling. Epididymitis, urethritis, infections of Cooper and Tyson glands. Treated with ceftriaxone, Rocephin, plus azithromycin. Send specimen to laboratory for culture. Instruct the patient that all sexual partners should also be treated. Instruct the patient to take complete prescription of the drug, if receiving ciprofloxacin, Cipro, or tetracycline for self-medication, even if symptoms have disappeared. Stress abstinence or condom use. Women, increased, foul-smelling vaginal discharge, dysuria, difficulty urinating, fever, abnormal or painful menstruation, vulval soreness, peritonitis, backache, lower back pain, usually involving only one side. Infertility, urethral and labial infection, risk of tubal pregnancy, pelvic inflammatory disease, PID, septicemia. Same as for male patients. Counsel the patient about potential complications. Describe the pathophysiology, signs, symptoms, complications, and medical treatment for syphilis. Syphilis, caused by spirochete, coiled bacterium, called Treponema pallidum. The organism is generally transmitted by sexual contact, but also can be spread through breaks in the skin. It also can be passed through the placenta, thus causing an infant to be born with the disease. Congenital syphilis. S/S, change throughout the course of the disease. If untreated, syphilis progresses through 4 stages: 1. Primary, 2. Secondary, 3. Latent, 4. Late. Primary stage, typical lesion, called a chancre, is the first sign of syphilis. The chancre is generally first noticed 1 to 12 weeks after contact. During primary stage, a reddish papule appears where the organism entered the body, usually on the genitals, anus, or mouth. Within 1 week, the papule becomes a painless red ulcer. Lymph nodes in the area of the chancre may be enlarged, but are not tender. The chancre may last from 1 to 5 weeks. When it disappears, patients may assume that they are cured when in fact, the infecting organism has moved into the blood. Secondary stage, occurs 1 to 6 months after contact. Symptoms may include a rash on the extremities, chest or back, palms of the hands, and soles of the feet. Pustules that contain highly contagious material often develop. Fever, sore throat, and generalized aching are also seen in this stage. The patient is contagious during the first and second stages. Latent stage, no symptoms exist. Although no symptoms are present, the organisms are invading the major organs. The infection is not spread by sexual contact during the latent stage, but may be transmitted by blood exposure. Late, tertiary, stage, generally 3 years after contact, before late syphilis develops, although it may be decades. Even without treatment, most patients never advance to this stage. S/S of late syphilis include arthritis, numbness of the extremities, lesions of the skin and internal organs, called gummas, and pain because of damage to the heart, blood vessels, especially the aorta, or CNS. Complications. Patient with untreated syphilis may develop severe, potentially fatal complications, including neurosyphilis, meningitis, blindness, paralysis, and cardiovascular disease. An infected woman who becomes pregnant has a greatly increased risk of fetal infection, deformities, or death. The lesions also make it easier for a person to transmit and contract HIV infection. Medical diagnosis, based on physical examination findings and a blood test to detect the presence of antibodies. Tests for syphilis include screening and confirmation tests. 2 screening tests are, 1, the Venereal Disease Research Laboratory (VDRL) test, and 2, the Rapid Plasma Regain (RPR) test. Both detect a protein that appears in the blood when a person has syphilis. Screening tests can be inaccurate because other factors can cause false positive reactions. In addition, the tests are not effective until antibodies for T. pallidum are present in the blood. This may not occur until 3 to 4 weeks after exposure. Confirmation tests, those that specifically detect T. pallidum, are needed to confirm the disease. They are the fluorescent treponemal antibody absorption (FTAABS) test and the microhemagglutinin test. Because patients with syphilis often have multiple infections, HIV testing is often recommended as well. Facilities that have the necessary equipment may use dark field examination of specimens to confirm the presence of spirochetes. Medical treatment. Treatment of choice is parenteral penicillin G unless contraindicated. For an infection of less than 1 year's duration, a single dose is usually sufficient. For infections of 1 year's duration or longer, a longer course of therapy is indicated. Neurosyphilis and other complications may require other drug therapy. Advise the patient to make a follow-up appointment with a physician to determine whether the treatment was effective. In addition, advise the patient not to engage in sexual activity until 1 month after completing treatment for primary or secondary syphilis. Pharm capsule. About 60% of patients treated for syphilis with penicillin experience the Jarisch-Herxheimer reaction. Patients have headache, fever, and muscle aches that persist for 12 to 24 hours after treatment. Patients who do not complete the prescribed course of anti-infective therapy may not be cured of the infection. Signs and symptoms. Possible complications. Mid-cal treatment. Nursing considerations. Primary syphilis. Chancre, round ulcer with well-defined margin, lesion thickened, rubbery, and painless. If untreated, the lesion persists only for 3 to 6 weeks and heals. Regional lymphadenopathy, enlarged lymph nodes only in the area of the chancre. Prompt, effective treatment can result in complete recovery without complications. Otherwise, the infection progresses to the secondary stage. Parenteral benzathine penicillin G is given IM in a single dose. If the patient is unable to take penicillin, PO tetracycline or doxycycline is used. Ensure that ordered blood studies are done. VDRL, RPR, FTAABS, assess for transient fever, flu-like symptoms, and malaise. Provide rest periods. Wear gloves to assess the skin and mucous membranes. Inspect for skin changes and lesions. Provide medications. After administration of parenteral antibiotics, observe the patient for 30 minutes for allergic reactions such as rash, fever, or chills. Have emergency drugs on hand in the event of anaphylaxis. Secondary syphilis. Sore throat, malaise, rash, fever, weight loss, headaches, musculoskeletal pain. May become latent without further problems or may progress to tertiary stage. Parenteral benzathine penicillin. Tertiary syphilis. Pain, areas that lack sensation, loss of position sense, abnormal gait, foot deformity, and ulcerations. Irreversible complications, arthritis, bursitis, osteitis, liver enlargement, heart disease, meningitis, CNS disorders. Benzathine penicillin doses at 1-week intervals. Describe the pathophysiology, signs, symptoms, complications, and medical treatment for herpes simplex. Herpes simplex. The herpes virus has plagued humans for many centuries. Several different types of the virus are passed easily from person to person. The virus that causes cold sores, herpes febrilus or herpes simplex virus 1, HSV1, was first described in AD 100 and is transmitted through contact with open lesions, usually on the lips or inside the mouth. Prevention strategies generally focus on avoiding direct contact, kissing. Nurses should use good hand-washing technique when caring for infected persons. The incidence of genital herpes, caused by herpes simplex virus 2, HSV2, has been on the rise since the 1960s. HSV2 is generally transmitted by sexual contact. Vaginal or anal intercourse and oral genital contact are the primary transmission modes, but HSV2 can be transferred by hand contact as well. Although HSV1 and HSV2 are similar, type 1 is usually non-genital, with lesions typically above the waist. Type 2 is considered an STI because it is most often below the waist and is transmitted by genital contact. A characteristic of herpes viruses is the ability to become latent. The virus can remain in the tissues in an inactive state for long periods of time and then be reactivated. Signs and symptoms. Symptoms of genital herpes infection include painful, itching sores on or around the genitals approximately 2 to 20 days after infection. These symptoms last about 2 to 3 weeks. A rash may appear first, followed by small blisters that eventually ulcerate. People often complain of flu-like symptoms and a burning sensation during urination. Episodes of active symptoms may recur and are frequently precipitated by anxiety, figure 55.2. Complications. An increased risk of cervical cancer exists in women who have genital herpes. An infected woman should be taught to have a Papa Nicolau, PAP, test done annually to detect cervical cancer early. If she is pregnant, a physician should supervise her closely. Various guidelines are used to determine whether the patient should have a vaginal delivery or a cesarean section. The goal is to decrease the risk of transmission to the baby. New diagnostic procedures allow the physician to detect active disease more accurately than in the past. Herpes simplex encephalitis is a dangerous complication, usually caused by HSV1. It has a mortality rate of 30% and half of survivors have moderate to severe neurologic impairment. Medical diagnosis and treatment. A diagnosis of HSV-2 may be suspected based on the appearance of genital lesions. Laboratory tests are used to confirm the diagnosis. These include antigen detection tests and NAAT using tissue or fluid specimens. Exudate from lesions can be examined under a microscope and cultured to reveal the virus. No cure for HSV infection exists, but the oral antiviral drugs acyclovir, Zovirax, valacyclovir, Valtrex, and famciclovir, Famvir, help by partially controlling the signs and symptoms during initial and recurrent episodes. Patients should know to start the drug when preliminary, prodromal, symptoms of recurrence are experienced or within 1 day of the outbreak of lesions. Some patients with especially disabling recurrences take one of these drugs continuously to reduce the frequency of outbreaks. Nursing care of the patient with HSV and other STIs is discussed in the section titled Nursing Care of the Patient with a Sexually Transmitted Infection. Table 55.5 summarizes the signs and symptoms of HSV infections, possible complications, medical treatment, and nursing considerations. Signs and symptoms. Possible complications. Medical treatment. Nursing considerations. Painful genital lesions, burning during urination. Localized infections, risk of infecting baby on delivery. Treatment is basically symptomatic and includes sitz baths. Acyclovir may minimize symptoms, however, no cure for herpes exists. Recurrences may be treated with acyclovir, valacyclovir, or famciclovir. Ensure that the patient notifies sexual contacts. Inform the patient that the virus can survive on objects such as towels. Assist in decreasing the patient's anxiety by allowing him or her to verbalize feelings. Instruct the patient to avoid sexual contact when lesions are present and to use condoms at other times. Describe the pathophysiology, signs, symptoms, complications, and medical treatment for trichomoniasis. Trichomoniasis. Trichomoniasis is caused by the protozoan parasite Trichomonas vaginalis and is usually sexually transmitted. However, the parasite can survive for hours on damp cloths and clothing. The CDC estimates that more than 7 million new cases occur each year. This infection usually affects the vagina in women and the urethra in men. Trichomoniasis is associated with an increased risk of HIV transmission. During pregnancy, it may cause premature birth or low birth weight. Signs and symptoms. Women typically complain of a frothy, yellowish vaginal discharge that has a foul odor. However, some women have no symptoms. Vaginal irritation and itching also may be present. Urinary frequency and burning suggest that the infection has invaded the urethra. If the infection becomes chronic, bladder and anal involvement are possible. Although the incidence of trichomoniasis is less common in men, it can certainly occur. Men usually have no symptoms, although some have a mild discharge or slight burning after urination or ejaculation. Medical diagnosis and treatment. The organism may be detected by microscopic study of vaginal discharge or urine in men. The discharge also can be cultured to reveal the organism. Tinidazole, Tindamax, is the drug of choice for treating trichomoniasis, with metronidazole, Flaggy, as a less expensive option. A single dose is usually effective. It is important that the patient and any sexual partners be treated at the same time to avoid reinfection. Describe the pathophysiology, signs, symptoms, complications, and medical treatment for human papillomavirus and bacterial vaginosis. Human papillomavirus. Most common STI in the U.S. with most common, more than 100 million types exist, but there are two types, low risk and high risk. High risk cervical, vulvar, vaginal, anal, penile cancer. Low risk, condylomata acuminata, genital warts, most common recognizable symptom affecting both men and women. Transmitted by vaginal, anal, or genital contact. Transmission can occur from people who have no visible signs of infection. Incubation period, 3 weeks 8 months. 2 vaccines. Gardasil protects against 4 types of HPV. Type 611 which cause warts and 16/18 which cause 70% of cervical cancers. Cervarix protects against 16/18 for a longer period of time. S/S, men, warts on glands, foreskin, urethral opening, penile shaft, scrotum. Women, warts on vulva, vagina, cervix, perineum, anal canal, urethra, labia. Deep within the vaginal canal, endocervix, oral, pharyngeal, laryngeal lesion also common. Condylomata warts are pink/red and soft with cauliflower-like appearance. Warts can become so large that they obstruct the vaginal/rectal canal. Warts grow larger in moist areas from vaginal/urethral discharge. Pregnancy stimulates growth of the warts. Diagnosis, observation of the warts, biopsy of lesions. When warts are present, physician also screen for cervical cancer as well as HPV. Treatment, removal of visible warts, application of Podophylax, imiquimod, cunnicatecins applied by patient. Physicians perform cryotherapy, topical trichloroacetic acid, bichloroacetic acid, podophyllin resin, surgical removal. Injection of interferon into the lesions, recurrence rates high. Describe the pathophysiology, signs, symptoms, complications, and medical treatment for HIV/B. Human immunodeficiency virus infection. Many diseases that cause illness or death have plagued Americans, but it is likely that none of these has had the profound medical, social, economic, and psychologic effects as has the HIV infection known as AIDS. This syndrome is a disorder of the immune system caused by HIV. HIV gradually destroys T4 lymphocytes, which are essential for resisting pathogens. As the number of T4 lymphocytes declines, the patient becomes increasingly susceptible to opportunistic infections. An opportunistic infection is one that thrives when the immune system is impaired. HIV is transmitted through exposure to body fluids. No cure for the infection exists, although combination drug therapy can delay progress of the disease. Health history. A thorough history is necessary to identify high-risk behaviors. A discussion of sexual behavior can be awkward for the nurse and the patient. Before nurses can deal with patients' sexuality, they must be aware of their own feelings and values. Privacy is essential for the patient interview. Questions about sexuality should be addressed in a straightforward manner. The interviewer should keep in mind that many patients lack scientific knowledge about the reproductive system and sexual activity. The patient may use some words that are considered crude by professionals, but the nurse must be careful not to embarrass or shame the patient. History of present illness. The history begins with an exploration of the patient's reason for seeking medical care. With an STI, common reasons include pain, fever, lesions, or genital discharge. Obtain a thorough description of the signs and symptoms, including onset, duration, and severity. Past medical history. In the discussion of past health, document serious conditions or chronic illnesses. The obstetric history may be significant as well. If the patient is of childbearing age, record the date of the last menstrual period. Record recent and current medications and note drug allergies. Review of systems. The review of systems elicits potentially significant signs and symptoms, including weight change, fever, weakness, fatigue, skin rashes or lesions, oral lesions, dysuria, whether the patient is sexually active, pain, lesions, or lumps in the genitals, vaginal or penile discharge, and altered sexual functioning. It is important to document a history of blood transfusions. Functional assessment. Relevant aspects of the functional assessment include frequency and variety of sexual behaviors, intravenous drug use, past infections with STIs, and sexual contact with a person known to have an STI. In addition, determine whether the patient may be classified as an at-risk patient because age, an adolescent experimenting with sexuality, sexual preference, men who have sex with men, or habits, drug use, place him or her at a higher risk for acquiring an STI. Victims of sexual abuse, of all ages, may have been exposed to STIs. Occupation may also be significant if the patient encounters potentially infected body fluids. Healthcare providers at risk for exposure include nursing personnel, physicians, emergency medical technicians, operating room technicians, housekeepers in healthcare facilities, and medical laboratory technicians. Physical examination. The physical examination begins with inspection of the patient's skin for rashes and lesions. During the head and neck examination, the mouth is inspected for lesions. Palpate the neck for enlarged lymph nodes. Inspect the abdomen for distension and palpate for tenderness. Depending on the setting and your specialized education, you may examine the genitals or assist the physician or nurse practitioner in the examination. The examiner wears gloves to examine the genitals. A good light source is essential for thorough inspection. In the male patient, the examiner notes the general appearance of the penis, scrotum, and anal area. Any skin breaks, rashes, or redness is noted. The LVN/LPN may prepare the female patient for a pelvic examination. While the patient is on the examination table and properly draped, the genitalia and the perianal area are inspected. The labia are separated and inspected for skin breaks, redness, or rashes. If a vaginal examination is to be done, ensure that the speculum and other supplies are ready. The speculum is warmed and lubricated before insertion in the vagina. Tissue and fluid specimens may be taken, including tissue scrapings for a Pap test. You may be responsible for preparing the specimen and sending it to the laboratory. In cases of sexual assault, it is especially important that the examiner be specially trained to deal with such situations. Not only does the patient need a great deal of support, but the examination may produce evidence that must be preserved for legal purposes. If a discharge is present, its color, amount, and consistency are recorded. Specimens may be collected for laboratory study. The specimen is handled as infective material, prepared according to agency procedures, labeled, and sent to the laboratory. Box 51-1. Assessment of the patient with a sexually transmitted infection. Health history. Reason for seeking care/present health. Pain, fever, lesions, genital discharge. Past medical history. Serious conditions, chronic conditions, hemophilia, obstetric history, date of last menstrual period, recent and current medications. Review of systems. Weight change, fever, weakness, fatigue, skin rashes or lesions, oral lesions, dysuria, whether sexually active, sexual contact with a person known to have a sexually transmitted infection, STI, sexual dysfunction, history of blood transfusions. Functional assessment. Frequency and variety of sexual behaviors, intravenous drug use, past STIs, sexual preference, occupational exposure to infective material. Physical examination. General survey. Distress, lethargy. Skin. Rashes, lesions. Mouth. Lesions. Abdomen. Distension, tenderness. Genitals. General appearance, lesions, rashes, redness, color, amount, odor, and consistency of discharge. Interventions. Impaired tissue integrity. If you have daily contact with the patient, assess the patient's skin on a daily basis. Record changes in lesions. Carry out orders for treatments, including topical medications and sitz baths, for patients in healthcare settings. Monitor the patient's temperature at regular intervals to detect fever that may accompany acute infection. Handle soiled clothing and bed linens in accordance with agency policy. Ensure that patients who will treat themselves at home understand the prescribed therapy and how to protect others from infection. Acute pain. Some STIs are painless, but patients may have pain associated with pelvic infection, oral lesions, or rectal lesions. The lesions of HSV are especially painful. Document the severity of the patient's pain and provide analgesics as ordered. Apply topical medications, ice packs, or warm compresses as ordered or teach the patient how to do so. Risk for injury. Untreated STIs can lead to serious complications such as PID and sterility. The patient with AIDS is at high risk for secondary infections, called opportunistic infections, because of impaired immune function. Infected patients also pose a threat to their sexual partners. An STI may be passed to the fetus in utero or transmitted during delivery. Therefore, it is important for the patient to receive the entire course of prescribed therapy. In addition, stress the importance of notifying sexual contacts so that they can be tested and treated as well, if necessary. Drug therapy has the potential for injury. Before administering medications, assess the patient's allergies. When injections are given to an outpatient, ask the patient to remain for 30 minutes afterward in case an allergic reaction occurs. Emergency drugs, including epinephrine, corticosteroids, and diphenhydramine hydrochloride, Benadryl, must be readily available. Anxiety. The patient may be anxious about the outcome of treatment and the potential complications of the disease. Anxiety may be heightened by the stigma associated with having contracted an STI, and the patient may feel ashamed. Encourage the patient to verbalize fears and frustrations. Provide accurate information and teach the patient how to avoid reinfection and infecting others. Patients with HIV infections also must deal with a life-threatening illness. Situational low self-esteem. The patient's self-esteem may suffer because of a diagnosed STI. Provide an opportunity for the patient to talk about the effects of the disease on self-concept. Try to guide the patient to focus on his or her positive attributes. If the patient's self-esteem remains low despite nursing intervention, a referral to a mental health counselor may be suggested. Impaired social interaction. A diagnosis of STI can be very distressing to the patient, who may fear rejection by others. The patient may be angry at the person who transmitted the infection and may be concerned about infecting others. Because STIs must be reported to public health authorities who attempt to trace all sexual contacts, the patient may also fear reprisals. One way you can help is by demonstrating acceptance of the patient through kindness and touch. Sexual dysfunction. Patients with STIs may experience sexual dysfunction related to fear of transmission, the presence of lesions, or anxiety. In addition, precautions that should be taken to prevent transmission of the disease may require changes in sexual practices. In general, sexual activity should be avoided until the infection is cured. Chronic infections such as HSV and HIV require permanent alterations in sexual activity. Explore the importance of sexual activity to the patient. Accept the patient's feelings in a non-judgmental way. Explain that emotions and sexual function are closely related, and that dysfunction may be overcome by dealing with the emotional reactions to the disease. For persistent dysfunction, advise the patient to discuss the problem with the physician. Offer to make a referral to a therapist who specializes in sexual dysfunction. Encourage the patient to communicate openly with the sexual partner about the difficulties experienced. Alternative means of sexual expression, other than intercourse, may be suggested. Ineffective coping. Ineffective coping may be related to guilt, shame, anger, actual or anticipated rejection, or a combination of these reactions. Behaviors associated with ineffective coping include failure to adhere to the prescribed treatment, failure to exercise precautions to prevent spread of the disease or reinfection, chronic anxiety or depression, and inability to cope. The patient with an HIV infection also must deal with the potential for developing AIDS, sometimes with inadequate personal support. Show support for the patient by being sensitive, courteous, and non-judgmental. Point out dangerous behaviors. Encourage the patient to evaluate his or her lifestyle and to identify modifications that could reduce future. You may refer patients who have HSV and HIV infections to support groups. A spiritual counselor also may be contacted if the patient desires. Ineffective self-health management. Patient teaching is essential for effective treatment and prevention of future infections. Explain to the patient what causes the infection, how it is transmitted, how it can be prevented, including safe sex practices, and why treatment and follow-up care are important. Knowledge does not guarantee compliance, but patients cannot comply unless they understand what they need to do to care for themselves. Determine what the patient knows about the infection. Provide information about the disease and its treatment in terms the patient can understand. If the patient can read, include supplementary written material. Stress the importance of completing the course of therapy and returning for follow-up to reduce the risk of complications associated with untreated disease. Evaluate the patient's understanding of the material covered and explore any barriers that might prevent the patient from following the instructions. Comparative safety of various sexual practices to prevent transmission of infection. Safe practices. mutual masturbation, closed-mouth kissing, body massage, use of own sex devices or toys, possibly safe practices, open-mouthed kissing, vaginal or anal intercourse with properly used condom, oral sex with properly used condom, unsafe practices, vaginal or anal intercourse without condom, oral sex without condom, multiple partners, properly used condom, oral anal contact, insertion of hand into vagina or rectum, ingestion of urine or semen, contact with blood, patient teaching, sexually transmitted infections. Be sure to complete the prescribed course of antibiotics and return so that the physician can determine whether the treatment was effective. Sexually transmitted infections, STIs, are transmitted by sexual contact. Avoid sexual contact with high-risk individuals, people who have had multiple sex partners, prostitutes, and those with known human immunodeficiency virus, HIV, or hepatitis B virus, HBV. Avoid sexual activity until your infection is cured. If you engage in sexual activity that involves any genital contact, use condoms. If you have sexual contact with high-risk individuals, people you do not know well, or persons who do not use condoms, you should have periodic medical examinations. Use condoms if you have condylomata. If you have herpes simplex virus, HSV, infection, you should abstain from sexual activity when lesions are present. Use condoms always. It is important to realize that although periods of remission are seen, the condition is chronic and transmissible. Women with HPV, HSV, or condylomata are advised to have annual Papa Nicolau tests because they are at increased risk of cervical cancer. If you have HIV infection, medical treatment may prevent or delay the development of acquired immunodeficiency syndrome, AIDS. Precautions must be taken to prevent infecting sexual partners, even though you may not have signs and symptoms of disease. Because HIV is transmitted through body fluids, you cannot donate blood if you are HIV positive. Drugs that help to prevent HIV, PrEP, must be taken regularly. Post-exposure HIV prophylaxis, PEP, must be taken within 72 hours of exposure. Patient teaching. Use of a condom. Condoms do not provide 100% protection against disease transmission. Latex condoms are preferred because some pathogens can pass through natural membrane condoms. Protect condoms from heat and sunlight to keep them from deteriorating. Do not use condoms that are brittle, discolored, or in damaged packages. Use only water-based lubricants because other lubricants can cause the condom to break. Spermicidal may be used. To put on a condom, hold it by the tip and unroll it onto the penis. Leave a space of about 1 inch at the tip for semen. Withdraw the penis carefully after ejaculation to prevent the condom from slipping off and spilling the contents and to avoid unprotected contact. Always discard used condoms for sanitary disposal.